I would now like to welcome our presenters for today's COCA Call. Our first presenter today is Captain Amanda Cohn. Captain Cohn is a medical officer and the lead for the vaccine planning unit as part of CDC's COVID-19 response. Our second presenter is Commander Sarah Imbe. Commander Imbe is a medical officer in the National Center for Immunization and Respiratory Diseases at CDC. And our third presenter is Lieutenant Commander Sarah Oliver. Lieutenant Commander Oliver is a co-lead for the Advisory Committee for Immunization Practices COVID-19 Vaccines Work Group as part of CDC's COVID-19 response. I would now like to turn it over to Captain Cohn. Captain Cohn, please proceed.
Great, good afternoon, everyone. Today we are going to provide an overview of what clinicians need to know about the Pfizer-BioNTech and Moderna COVID-19 vaccines. We will be reviewing some new information as well as reviewing some information that we've presented over the last couple of weeks on either COCA or other partner calls. Next slide. So both of these vaccines are mRNA COVID-19 vaccines. In the next week, we'll have two products likely to be available. The Pfizer-BioNTech vaccine was authorized by the FDA on December 11th, and BIRPAC voted to support authorization of the Moderna vaccine yesterday on December 17th, and we anticipate that FDA will authorize that product as well in the next couple of days. Both products demonstrate a vaccine effectiveness of greater than 90%, and this effectiveness was demonstrated across age groups and racial and ethnic groups. The vaccine safety profile of both products are also acceptable. There was an imbalance of Bell's palsy cases reported after vaccination for both products, but this was still within expected range and will be continued to be monitored. And local and systemic reactogenicity, particularly after the second dose, occurred, but was also expected and resolved relatively quickly in a couple of days. The take-home message about these two vaccine products is they shouldn't be compared with each other at this time. They both appear effective and safe. And looking at information such as whether or not one product causes more fever than the other or is more effective in certain groups than other, you have to take into account the populations that were different for these two vaccine clinical trials, as well as the way that they solicited adverse events and the adverse events that they solicited for. So while there appear to be small differences in these two products, if you look just at the vaccinated group, if you look at the vaccinated compared to the placebo group for adverse events, they do appear quite comparable. Next slide. I'm going to take a moment to explain messenger RNA vaccines. And these next three slides, these were publicly presented vaccine slides that were presented at the BIRPAC meeting by Moderna yesterday, but apply to both vaccines in general. Messenger RNA vaccines provide instructions directly to the immune system of the individual getting vaccinated. The spike protein is the protein that the messenger RNA codes for. This efficiently produces a specific immune memory response in a natural context. So this is very similar to how the immune response would happen if you were exposed to the virus. However, there is no live virus in this vaccine, and the mRNA can neither interact with nor integrate into the DNA. Next slide. This goes into a little bit more detail. So the spike protein encoded mRNA and the lipid nanoparticles that encase the mRNA are the only ingredients in these vaccines. The lipid nanoparticles allows these vaccines to travel to the lymph system and enter antigen presenting cells. So the encoded mRNA is then read by the ribosome. The viral spike protein is produced and then presented on the surface of the cell. Importantly, we know from studies that the company has done that the mRNA disintegrates or is broken down by the cell very quickly. And we know that the lipid nanoparticles also don't stay in the system for more than a couple of days. Next slide. This is just one more additional slide to explain how the immune response occurs. So after the spike protein is presented on the surface of the antigen presenting cell, that elicits a B cell response and elicits neutralizing antibodies. But importantly, it also induces a CD4 and CD8 T cell response so that immune memory is elicited. Next slide. Many of the ingredients in these two vaccines are the same, but there are some particular differences. Both have mRNA encoding the viral spike glycoprotein of SARS-CoV-2, and each of them contain 4 lipid nanoparticles, 2 of which are the same and 2 of which are different by product. They do contain buffering salts and sugars, but there are no preservatives or adjuvants in these products. Next slide. I'm next going to review the Advisory Committee for Immunization Practices. So after FDA authorization on December 12, 2020, ACIP recommended the use of the Pfizer-BioNTech COVID-19 vaccine in persons 16 years of age and older under FDA's emergency use authorization. On December 19th, which is tomorrow, ACIP will consider use of the Moderna COVID-19 vaccine in persons 18 years of age and older. If the vaccine is authorized by the FDA, ACIP will vote tomorrow. So the big difference between these two vaccine products are the age group for which the FDA emergency use authorization goes down to. It's 16 versus 18. The other big difference in these vaccines, while they are both 2-dose vaccine series, the Pfizer product is 21 days apart, and the Moderna product is given 28 days apart. ACIP has also made recommendations about prioritization of certain groups. So ACIP recommends that when a COVID vaccine is authorized by FDA, which it has been, and recommended by ACIP, that healthcare personnel and residents of long-term care facilities be offered vaccination in the initial phase. This is phase 1A. And to let everyone know, ACIP is considering the next prioritization groups, so phase 1B and 1C, on Sunday, December 20th, 2020. And we anticipate having all prioritization groups completed by Sunday, where the next final group would be all adults not included in one of those groups. Next slide. To complement the ACIP recommendations, CDC has also published on our website clinical considerations for the use of the Pfizer-BioNTech COVID vaccine. These were presented last week and are available at this link on our website. These clinical considerations will be updated to include information on both authorized mRNA vaccine products. We anticipate that the clinical considerations for both will be nearly identical at this time for both products, other than the 2 differences that I just mentioned. There may be some other small differences, but we're trying to align the clinical guidance as closely as possible, regardless of the product. That does not mean the products are interchangeable. These clinical guidance was informed by data submitted to FDA for the EUA of the vaccine, other data sources, and we relied heavily on the general best practice guidelines for immunization, as well as expert opinion. We will continue to update these clinical guidance documents as we understand these vaccines more. Next slide. A couple of key highlights to make from these clinical considerations is that we want clinical providers to understand that these vaccines are reactogenic. So before vaccination, providers should counsel vaccine recipients about expected local and systemic post-vaccination symptoms. This is particularly true, while true for both doses, is that it's particularly true for the second dose. And this includes things like redness, pain, and fevers and myalgias after vaccination that resolve within 24 to 48 hours. Unless a person develops a contraindication to vaccination, they should be encouraged to complete the series, even if they develop post-vaccination symptoms, in order to optimize protection against COVID-19. At this time, we don't have data to support use of a single dose of vaccine. Next is that antipyretic or analgesic medications may be taken for treatment of post-vaccination symptoms, but we don't recommend routine prophylaxis for the purposes of preventing symptoms due to lack of information on the impact of its use on vaccine-induced antibody responses. And the link for this is included below. Next slide. The other really important things to counsel your patients and for all of you to understand is that protection from vaccination is not immediate. The vaccine is a 2-dose series and will take 1 to 2 weeks following the second dose to be considered fully vaccinated. Additionally, no vaccine is 100% effective. So given the current limited information on how well the vaccine works in the general population, how much it may reduce disease, severity, or transmission, and how long protection lasts, we are recommending that vaccinated persons continue to follow all current guidance to protect themselves and others, including all of these things you see below, which are normal social distancing guidance. We do recommend that an individual follows quarantine guidance after exposure to somebody with COVID-19, even if vaccinated, and following any applicable workplace or school guidance. Next slide. We'll talk about this a little bit more in the question and answer period, but we do have in our clinical guidance an algorithm to support triaging persons presenting for mRNA vaccines. And the green column indicates conditions in which you may proceed with vaccination. The second column is conditions which are considered a precaution to vaccination. And the third column is contraindications to vaccination. This is split up into 2 rows. The first row is conditions. So things like immunocompromising conditions, pregnancy and lactation. A person may proceed with vaccination, but additional information should be provided to those individuals. Additionally, any history of allergy to food, to pets, to insects, or allergies not related to vaccines or injectable therapies can proceed with vaccination, but we recommend a 30-minute observation period for persons with a history of severe allergic reaction due to any cause. Precautions include moderate to severe illness or unstable illness, as well as history of severe allergic reactions to another vaccine or history of severe allergic reactions to any injectable therapy. That would require a risk assessment, deferral, consider deferring vaccination, and if an individual does get vaccinated, implementing a 30-minute observation period. Finally, there are no conditions which are contraindications to vaccination. The only allergic reaction is a history of severe allergic reaction to any component of the Pfizer-BioNTech, and this will also include tomorrow or whenever the vaccine is authorized, the Moderna vaccine as well. And these are individuals that should not get vaccinated. Next slide. There have been reports of anaphylaxis after vaccination, both from the United Kingdom, as well as cases that are being investigated at this time in the United States. We are investigating this and understanding these allergic reactions more fully. But in the interim, we want to ensure that all institutions or groups that are administering vaccine prepare for the potential management of anaphylaxis at any vaccination sites. So we do have an additional focus interim considerations for management of anaphylaxis, which includes information on early recognition, medication and supplies, management of anaphylaxis, and recommendation to immediately activate EMS if there is an anaphylactic reaction, and patient counseling and reporting. Next slide. These are the recommended medications and supplies that sites should have available to manage anaphylaxis. Epinephrine, antihistamines, blood pressure cuffs, stethoscope, and timing device to assess pulse should be available at all sites. And then there's some additional sites recommendations to include at sites where feasible. Really, the most important thing to do is to administer epinephrine and call 911 if any individual is experiencing an anaphylactic reaction. Next slide. So I want to highlight that we have multiple COVID-19 vaccine communication resources for healthcare providers, for medical centers, both how to engage in effective COVID-19 vaccine recommendations. A strong recommendation from a healthcare provider, we know, is one of the most important things to inform a person's decision to get vaccinated. And even if you're a healthcare provider who's not administering vaccine at this time, all of you see patients every day and can recommend vaccination when it's the right time for that individual to get vaccinated. We also have a toolkit with multiple posters and stickers and slide presentations to talk to both healthcare personnel in your institution or medical practice and as well as your patients. So we do have more toolkits that will be available soon, including ones for long-term care facilities, for health departments, for community-based organizations, and for employers of essential workers. Next slide. One other key set of documents we want to point out is that we have developed infection prevention and control recommendations for persons with post-vaccination symptoms. This is really important both for healthcare personnel as well as long-term care facility residents. And it helps build out a framework for determining, we don't want to unnecessarily exclude healthcare personnel who only have post-vaccination signs and symptoms from work. But we also don't want to inadvertently allow healthcare personnel with SARS-CoV-2 or another transmissible infection to work. So these are both available on our website as well. Next slide. So we will now move to the second part of our session, where I will be asking questions and moderating a panel discussion with Dr. Mabai and Dr. Oliver. These questions have been taken from the multiple questions that we've received from healthcare providers, including during our last COCA call over the last week to 10 days. We really want to hear your questions. It has helped us so much in understanding what clinical guidance we need to have available to healthcare providers. So please continue to put questions that you have in the Q&A as we go through these questions and have this discussion. So I will begin with a question that I've asked and answered a couple of times, but I'm going to ask Dr. Oliver to talk about this because fortunately, I think the answer is evolving. But what do we know currently about the benefits of mRNA COVID-19 vaccines to prevent transmission of SARS-CoV-2?
Thank you, Dr. Cohen. So the vaccine manufacturers of the Pfizer-BioNTech vaccine has stated that they're doing additional studies to better understand the vaccine's impact on transmission. We look forward to being able to review that data when it's available. Yesterday, information was presented at the VRBPAC meeting for the Moderna vaccine. Among people who received one dose of the Moderna vaccine, there was a reduction in the number of participants who were asymptomatic but had a positive PCR compared to those participants who received placebo. And this screening was done when the participants came back in to receive their second dose of vaccine. It's early data, and we still need to know more around how these mRNA vaccines will prevent transmission. But overall, it's encouraging from the clinical trials, and we look forward to additional information around how these vaccines may prevent transmission. Until we have that additional information and until there's high vaccination coverage in the general population, we do want to continue to encourage that and recommend that vaccinated people continue to use all of the tools available for preventing COVID-19, including mask use, social distancing, and hand hygiene even after vaccination.
Great, thanks so much. Yeah, I do think I'm really looking forward to this information, and I am really excited about the small amount of encouraging data that was presented yesterday. So Dr. Oliver, I will also, since y'all are both Sarahs, I'm using doctor instead of your first name because y'all won't know who I'm asking. Sarah Oliver, what should people who have had COVID-19 be vaccinated, and should they be vaccinated now?
Thanks. So COVID-19 vaccination should be offered to persons regardless of prior COVID-19 infection. Data from both clinical trials suggest that people with prior infection are still likely to benefit from vaccination. We're not recommending that anyone have an antibody test prior to vaccination. However, people who are acutely ill with symptomatic COVID-19 should wait to get vaccinated until after their acute illness is resolved and after they've met the criteria to discontinue isolation. There is current evidence, though, that reinfection with SARS-CoV-2 is uncommon in at least the 90 days after initial infection. So because of that, persons with a recent COVID infection may defer vaccination until the end of that 90-day period, if desired.
Great. So I'm going to take this question one step further. What if, for example, I get dose 1, and then when I'm due for dose 2, what if A, I have symptomatic COVID and I'm ill? And B, what if I have a positive PCR test showing I have asymptomatic COVID? Should I get that second dose?
So anybody, again, who's kind of currently ill with symptomatic COVID should wait until after their acute illness is resolved. We really want to protect the healthcare personnel and people who would be providing the vaccine and not expose them to risk. There are certain circumstances that are detailed in the clinical considerations, especially around quarantining individuals, where people residing in congregate care settings, when they're under quarantine, may still receive vaccines. But overall, individuals who are positive should wait to receive vaccine until they've met the criteria to discontinue isolation, especially to provide that extra layer of protection to the healthcare personnel who may be administering that vaccine.
Great, thanks so much. So it's not for concern about us being, it's not about concern for vaccine safety for getting that vaccine. It's really about maintaining our quarantining recommendations and protecting healthcare workers.
Exactly.
Great. Okay. Moving on to what I know is a question that is at the top of everyone's minds and has been really challenging to sort through. Dr. Mabai, can you talk a little bit about the contraindications to components of the Pfizer-BioNTech and Moderna vaccine, and what does it mean in terms of what kinds of things would you think about in terms of being concerned about whether or not you have had a severe allergic reaction to one of those components in either vaccine? And what should people be thinking about in terms of severe versus less severe allergic reactions and anaphylaxis?
Sure, thank you, Dr. Cohn, for that question. So as as you mentioned a little bit earlier, so there are some people that should absolutely not get this vaccine. And those are people that have had a severe allergic reaction to any component of the vaccine. And, I just wanted to point out one of the components that Dr. Cohn showed, contains polyethylene glycol. So that's something that, clinicians are used to using for things like laxatives or colonic bowel prep. So for example, if somebody had an anaphylactic reaction to that medication, that's a component of the vaccine. That's kind of the main one of concern. But people who have had a reaction to any component of the vaccine should not get it. If somebody gets the first dose of the vaccine and experiences anaphylaxis, they should not get a second dose of the vaccine. In terms of, how, people can decide, was this a serious reaction, like anaphylaxis or not, when they're talking to their patient? Some things like eliciting, did it require use of an EpiPen? Did it require, hospitalization or, visit to the emergency room, or really trying to elicit those symptoms to see how severe an allergic reaction might have been. So there's those people that, shouldn't get the vaccine, but there's also that group of people who, there's some precautions around the vaccine, and there should really be, a history elicit a little bit more. So somebody who's had a severe allergic reaction to any vaccine or any injectable medication at this time, we're recommending that those are precautions around the vaccine. Somebody can still get the vaccine, but there needs to be that discussion to really better understand what happened and take into account, some, kind of various factors to determine whether that person should get the vaccine. As Dr. Cohn mentioned, people with things like food allergies, insect allergies, latex allergies, those kinds of things, those people, we don't have any sort of contraindication or precaution to people with other types of allergies. Having said that, everybody who gets the vaccine, we're recommending an observation period. So for anybody that has a history of anaphylaxis due to any reason at all, we're recommending a 30-minute observation period. For everybody else who's never had anaphylaxis in their life, we're recommending a 15-minute observation period.
Great. So, I have a daughter who carries an EpiPen. I've never had to use it before, but is allergic to certain tree nuts. You would recommend that she go ahead and get vaccinated when she's old enough, she's 18. Would you recommend that she go ahead and get vaccinated when she's recommended based on prioritization, but you watch her for 15 minutes to 30 minutes? Is that the advice for what we know are many, many people who are concerned about anaphylaxis, but haven't had to use that EpiPen before?
Yeah, that's right. People who have other, types of allergies, who've experienced allergic reactions, but have never had, a severe reaction such as anaphylaxis. A lot of people get EpiPens. They're given that. But unless somebody's had a, anaphylactic reaction in the past to a, vaccine or injectable medication, they can get the vaccine. They just need to be observed afterwards.
Great, thank you. And I apologize. Those are unfortunately my dogs. Somebody rang the doorbell. Okay, let's move on to the next question. So Sarah, can you go into a little bit more detail about what is needed on site at vaccination clinics? I know I talked about this a little bit, but do you have anything else to add about what sites can do to make sure they're prepared to vaccinate in case there is anaphylaxis?
Yeah, I think the key things that people need to do are make sure that at their vaccination site, that whoever is, administering the vaccines or involved in that process should be able to, rapidly recognize the signs and symptoms of anaphylaxis, to, give epinephrine. Epinephrine is first-line treatment. There are, no contraindications to giving epinephrine. If somebody has anaphylaxis, you want to give that epinephrine immediately, and then, call for emergency services, call for 911. And so I think, those are kind of, I think, the main take-home messages. We did prepare kind of some recommendations of the minimum that people need to have on site. And I think the minimum, really, like I mentioned, is epinephrine. We do recommend that people have, antihistamines on site, such as diphenhydramine. That doesn't treat anaphylaxis. That doesn't treat the, respiratory obstruction and things like that, but it can provide symptomatic relief for people that need it. We do recommend some equipment to help monitor vital signs or assess vital signs. So blood pressure cuff, stethoscope, something to time somebody's pulse. And then there's the other things that, are used for treatment of anaphylaxis that if you have it or if you're able to get it, the more you can be prepared, the better. But I think what I mentioned are really kind of the minimum requirements. But again, being able to recognize anaphylaxis, administer epinephrine appropriately, and call for emergency services are kind of the ABCs for vaccination sites to do.
Great, thank you. So, Dr. Mabai, I know in some types of settings it can be really challenging to recognize anaphylaxis. For example, if an individual who's living in a long-term care facility setting, who may have some dementia and can't report symptoms, if you are sort of on the fence about whether or not that individual is having an anaphylactic reaction, you're saying that you go ahead and give epinephrine regardless, right? And then call 911.
Yes, if anaphylaxis is suspected, epinephrine is a life-saving treatment, and delays in administering it can create bad outcomes. I do want to mention, as you mentioned, it can be hard in some patients to tell, and hindsight is always 20/20. I do want to mention that some older adults, especially those who have certain cardiac issues like hypertension, atherosclerotic disease, they are more at risk for, kind of a cardiac side effects from epinephrine itself. So, you certainly don't want to give unnecessary doses when people don't need it. But, like I mentioned, because of how life-threatening anaphylaxis can be and rapid, prompt attention to it is necessary, if anaphylaxis is suspected, you should administer it and then call 911.
Great, thank you. I guess to close out the questions on anaphylaxis, I think I'd just like to make the comment that, we are not saying that this anaphylaxis still is rare. But if these reports do end up turning out to have been real anaphylaxis, and it is occurring at a more than regular rate, we usually anaphylaxis to vaccines is more than 1 in a million. It's about 1 in about 1.3 million persons vaccinated. We are vaccinating a lot of people over the next couple of months. And if it's lower than that, if it's 1 in 100,000 or 1 in 500,000, the benefits of vaccination are really important. But we will be doing whatever we can to understand what is causing anaphylaxis and supporting continuing vaccination unless there's a real need to shift. I will say the cases that have been reported have all been reported from Pfizer vaccine, and it's still really a handful. We do not know if this will happen with Moderna vaccine, but we are maintaining the same clinical guidance for both vaccines until we know otherwise. So moving on to vaccination we're going to talk about some special populations. And I know a lot of this information is in that clinical considerations document, but as you know, the vaccine clinical trials did not include known pregnant women. So Dr. Oliver, can you talk a little bit about whether or not pregnant persons can get mRNA vaccines and if there are special considerations for pregnant women?
Absolutely. So if a pregnant person is a part of a group that is recommended to receive a COVID-19 vaccine, so such as a healthcare personnel, then they may choose to be vaccinated. While we think a conversation with a healthcare provider may be helpful in helping the pregnant individual make that decision, but it's not required prior to vaccination. I think from the clinician standpoint, when thinking through talking with a pregnant patient, providers need to think through what we know and don't know about vaccines during pregnancy. So based on our current knowledge and leading up to these recommendations, we really pulled together some of kind of the country's experts in this technology and in pregnancy and in pregnant women. The experts believe that mRNA vaccines are unlikely to pose a risk for people who are pregnant, just based on the biology of how these mRNA vaccines work. The mRNA vaccines are not live. The mRNA degrades quickly after vaccination. There's not been any safety threats that have been identified. Observational data demonstrate that while the absolute risk is low, pregnant people with COVID-19 have an increased risk of severe illness, including illness that has resulted in an ICU admission, mechanical ventilation, or death. And they also may be at increased risk for adverse pregnancy outcomes, such as preterm births. So while there's no data on the safety of these vaccines in pregnant people, those studies are ongoing. Watching how these, there were some inadvertent pregnancies in the clinical trials. And in both the Pfizer and Moderna trials, the manufacturers and FDA and CDC are going to follow and see how those pregnancies progress and the outcomes. There have not been any safety issues identified to date. And then the animal studies, so we call those the DART, the developmental and reproductive toxicity studies, those are ongoing and we expect to have those results very soon. Hopefully the studies in pregnant people specifically are planned and will be beginning soon as well. I think the clinician also needs to consider some other factors when discussing this with pregnant patients, including the patient's risk of exposure to COVID based on their occupation, such as the exposure in a healthcare setting, if they're a healthcare personnel, and the level of COVID in the community, risk of COVID related to complications for them and the baby, the benefits of the vaccine and the known side effects, and the lack of data around mRNA vaccine and during pregnancy, balancing that with what we do know.
Great. And you just reminded me, I'm going to give a plug for vSafe, which is the active safety monitoring system that we are asking people who get vaccinated to enroll in. It's a text message based system where we're collecting information on people's adverse events. If they have a significant health impact after vaccination, we're following up with phone calls to understand that health impact better. And so we are reminding people to, we're asking people to let us know how they're doing up to 2 weeks after vaccination, and then at a couple of additional time points. We've really had incredible uptake of persons enrolling in vSafe in this first week of vaccination. I've been so happy because it's really going to give us the most timely and it's going to really help inform how to use these vaccines effectively and safely. I will also say that vSafe is following individuals who are getting vaccinated who are pregnant. And so if a patient or if any of you are pregnant and get vaccinated, we really want to understand vaccine safety in pregnant individuals. So we already have more pregnant women enrolled in vSafe than we had in the clinical trials. and or that were vaccinated with not knowing they were pregnant in the clinical trials. So we're really excited about that. Sarah, can I, Dr. Oliver, can I ask you then about lactating women? Does the same hold true?
Yes, absolutely. So there's no data, again, on the safety of the COVID vaccines in lactating people or in the effects of mRNA vaccines on a breastfed infant or on milk production or excretion. However, mRNA vaccines are not thought to be a risk to a breastfeeding infant. So a lactating person who is a part of a group that's otherwise recommended to receive COVID-19 vaccine, so for example, in phase 1A, the healthcare personnel, they may choose to be vaccinated as well.
Great. And can you, before we leave this topic, can you just give us an update about other provider organizations such as ACOG and clinical guidance that they've released as well?
Yes. So CDC, when CDC and ECIP were developing these clinical considerations, we did it in close collaboration with ACOG and AAP. And ACOG has released a practice advisory that is available online, and the pregnancy webpage on the COVID vaccine site specifically links to that ACOG practice advisory as well. So I think recognizing that some of the burden of walking through the risks and the benefits is going to fall to these OBGYNs and providers that people may turn to for questions, ACOG has committed to kind of providing that information and support in addition to what's available from the CDC website.
Great, thanks. Now moving to the topic of immunocompromised persons. We're going to turn back to Dr. Mabai. I know in the triage slide that persons who are immunocompromised are not considered a precaution or a contraindication for vaccination. But there's a lot of questions. There's a wide range of immunocompromised persons and persons receiving medications like biologics. So what are the current, what is the guidance for individuals who have who are immunocompromised and around receiving an mRNA vaccine, COVID vaccine?
Yes. So as you mentioned, people with who are immune compromised can receive the vaccine unless they have any other contraindications that were already mentioned. People with stable HIV were included in the clinical trials. Other people with other types of immunosuppression were not included. So we really don't know right now kind of the benefits and risks of the vaccine for them, or the safety and efficacy. But these people, we believe to be, might be at risk of severe COVID disease. So there is really kind of that risk balance ratio that needs to be taken into account. So what we're saying is that, people with, immunosuppression can get the vaccine. They should just be aware that, we don't really have that much data, and the vaccine may not work as well. They may have some diminished immune responses, which makes it, important for them to continue with all the public health measures that Amanda mentioned were still recommended for everybody, like washing, social distancing, masking, all of those kind of things to help keep themselves safe. Great.
And is this similar for persons with autoimmune disease? I know there's a lot of concerns about autoimmune disease and these vaccines, and what are the current recommendations or guidance around that?
Yes, it's a similar recommendation. We really don't have much data in this particular group, but people with autoimmune disease, they were eligible to be enrolled in the clinical trials. So they were able to take part in the clinical trials, and there weren't any, there was no, there were no data available specifically in this group, but when FDA reviewed the data, they didn't find any kind of imbalances between the vaccinated group and the unvaccinated and the placebo group in terms of occurrence of symptoms consistent with autoimmune diseases. So, we recommend, these people with autoimmune diseases or persons on biologic treatment, they can get the vaccine unless they have, unless they have a medical contraindication, such as, the anaphylaxis issues that we were talking about earlier.
Great. And then final question in this grouping. So what if, I know we're saying that people who have had COVID-19 should be vaccinated. They can, if you're trying to prioritize, you could defer vaccination for 90 days in those individuals. But how are the recommendations changed if a person received monoclonal antibody or received convalescent serum when they were treated for COVID-19?
So yes, it's a great question. We don't have data on this in terms of how soon after somebody gets a monoclonal antibody treatment or a convalescent serum, the safety, efficacy, all of those parameters. But we do know some things about the half-life of how long monoclonal antibodies, would last in the system. So based on that information, we're saying that, people who have received monoclonal antibodies or convalescent serum, they should delay vaccination for at least 90 days after treatment. And this is a precautionary measure until we have additional information available. And this is to help avoid interference of the antibody treatment with vaccine-induced immune responses. So it's kind of based on what we know about these therapies, but also knowing that people who have been recently infected with SARS-CoV-2 are unlikely to have reinfection in those 90 days, initial 90 days. So we're saying wait 90 days to get the vaccine if you've had monoclonal antibodies or convalescent plasma.
Thank you. So Dr. Oliver, a couple of questions about dosing and administration of these vaccines. So as you know, it's next to impossible to make sure that everybody gets back to get their second dose right at 21 days or right at 28 days. So can you talk a little bit about what happens if a person comes in before 21 days or 28 days, depending on the product, or after? What are the recommendations to manage differences in time intervals between doses?
Sure. So the Pfizer vaccine is recommended an interval of 21 days. The Moderna vaccine is recommended at an interval of 28 days. The reason for this is simply based on how the studies were designed, that Pfizer gave the vaccine in their trial at 21 days and Moderna did at 28 days, and not based on any specific concerns around how the vaccines work. But well aware that it's difficult, especially if the products are different, to know exactly when everybody should come back in the second dose scheduling. So we've had some kind of intervals where things are okay based on data from the clinical trials. So they said that a 4-day grace period before should be fine. In addition, there's no maximum interval between the first dose and the second dose. So if a person, if there is a delay in receiving the second dose, they should receive the second dose as soon as possible after that kind of 21 or 28-day interval. And you don't have to start the series over again. At this point, there's no recommendation where we restart the series or need to repeat doses. A person receives 2 doses of these mRNA vaccines, and especially in the setting of limited supply, that's what's recommended right now.
Great, thank you. That makes a lot of sense. And we do have lots of systems in place, electronic systems and at the state and local health department level to support people having reminders to get back for their second doses. And hopefully a lot of people are getting their second dose scheduled at this time when they come in for their first dose. But certainly as vaccination expands, I think that's going to be a challenge. And so hopefully we'll have more data to inform effectiveness with differences in administration dates. One more question for you, Dr. Oliver, about that we've also gotten a ton of questions about. Can influenza or any other vaccine be administered at the same time as other COVID-19 vaccines?
So right now, we're recommending that the mRNA vaccines be given alone with a minimum interval of 14 days before or after administration. If an mRNA vaccine is inadvertently administered within 14 days of another vaccine, providers don't need to repeat the dose or restart the series of the mRNA vaccine. And again, this is mostly in this period of time where we're trying to learn about, monitoring these vaccines. We just want to have a very clear picture of what is happening specifically related to the mRNA vaccines. And if an individual receives, multiple vaccines at the same time, it could be hard to figure out kind of what's going on in that picture. So for right now, we're saying the mRNA vaccine given alone with an interval of 14 days before and after, with the knowledge that as this expands and as we learn more, we'll update that recommendation.
No, that's great. But if a person comes in and can't remember they got their flu vaccine a couple of weeks ago, you don't have to track that down. You can go ahead and administer it and not have to repeat it. But the goal is to be 14 days apart. Yeah, this is I really understand in all of our other routine immunization guidance, we recommend co-administration of vaccines because we want to use every opportunity to get people up to date. I think this vaccine is still under an emergency use authorization, and clinical trials were not done that included co-administration. And so, we will shift our guidance when we feel we have the data to support that, but for right now, try to administer this alone and within 14 days before or after another vaccine. So Dr. Mabai, could you talk a little bit, I think this is going to be our last question. I know, myself, as long as and I'm guessing most of the providers on this call have never actually administered a vaccine or potentially anything other than a diagnostic test under an EUA. So could you talk a little bit about what providers need to report, what they need to do, and what are the requirements around administering COVID-19 vaccines under an EUA?
Sure, yes, it is a great question that I know probably a lot of people need more information on. So I think first, all COVID-19 vaccine providers should really carefully review these requirements that are in the COVID-19 vaccine provider agreement. And this includes following CDC, ACIP, and the manufacturer's recommendations for the storage, handling, and administration of COVID-19 vaccines. They also should be familiar with the information in the EUA fact sheet for healthcare providers administering the vaccine. And as we talked about before, be prepared to medically manage any severe reactions that may occur. And then all patients must be provided with the EUA fact sheet for recipients. They should be given this prior to vaccination. And there's also a vaccination record card or a shot card that comes in the ancillary kit for vaccination, and that completed vaccination record card should be given to each patient so that they know what they got, what vaccine they got, and when they need to come back to get their second shot. And then vaccines administered should be documented in the patient's medical records within 24 hours of administration. So we suggest, vaccine providers should use make their best efforts to report the administration data to their jurisdiction, either through their jurisdiction's IIS or CDC's Vaccine Administration Management System, which we've been calling VAMS, as soon as it's practical, but ideally no later than 72 hours after administration. Providers are also required to report their vaccine inventory to Vaccine Finder daily, and they must report to the Vaccine Adverse Events Reporting System, or VAERS, for any vaccine administration errors, even if there was no associated adverse event, all serious adverse events, regardless of whether they think it's vaccine related or not, multi-system inflammatory syndrome in children and adults, and as well as cases of COVID-19 that result in hospitalization or death following vaccination. In addition to these, any clinically significant adverse events may also be reported to VAERS, even if the provider is not sure whether or not vaccination caused that. And there's also, additional requirements in FDA's conditions of use that are, kind of on FDA's website. And again, like Amanda mentioned, we're also encouraging providers to ask their vaccinated patients to participate in the V-Safe program, which is the voluntary monitoring system that would help us kind of understand the safety, outside of clinical trials. So I know that was a lot of information, but that information is found in the vaccine provider agreement, and that information is also available on our website as well.
Great, thanks so much. And I know that a primary reason to report through the IIS is to make sure that patients do get the same vaccine. But I will also tell you that all of this data that is coming in and being reported by all of you is incredibly helpful as we assess potential adverse events. It gives us denominator data that's really quite critical. So we really appreciate it. And Drs. Mabai and Oliver, I also appreciate you doing this today with us. And Abad, I can hand it back over to you.
Thank you, Captain Cohn. Next slide, please. Captain Cohn, here are some resources. Would you like to remark on these?
Sure, we did just put some general information, but this is with the for the Pfizer EUA and information about COVID vaccines from the FDA website. There will be, once Moderna EUA is authorized, similar information will be available for the Moderna product. I did peruse FDA's website this morning, and the patient fact sheets have actually been translated into multiple languages already, which is incredible. So always, if you need anything like that related to the EUA specifically, go to any of these links on the FDA's website.
Thank you very much. I want to thank everyone for joining us today, with a special thank you to our presenters, Captain Cohn, Commander Mbe, and Lieutenant Commander Oliver. Thank you so much for providing our audience with such critical information. Today's COCA Call will be available on demand a few hours after the live call. You can find the video recording of today's call at emergency.cdc.gov/COCA. Please continue to visit emergency.cdc.gov/COCA to get more details about this call and others, as we intend to host COCA calls to keep you informed of the latest guidance and updates on COVID-19. Be sure to subscribe to receive notifications about upcoming COCA calls at emergency.cdc.gov/COCA. COCA Call announcements for upcoming COCA calls and other COCA products are sent via email. In addition to visiting our webpage, please remember to subscribe to COCA to receive notifications about upcoming COCA calls or other COCA products and services. Subscribe by going to emergency.cdc.gov/COCA/subscribe.asp. Again, that's emergency.cdc.gov/COCA/subscribe.asp. Please share the call announcements with your clinical colleagues. You can join the COCA mailing list by visiting the COCA webpage at emergency.cdc.gov/COCA. Click on Get Email Updates and enter your email address. To stay connected to the latest news from COCA, be sure to like and follow us on Facebook at facebook.com/CDC Clinician Outreach and Communication Activity. Again, Thank you for joining us for today's COCA Call and have a great day.